Abdominal compartment syndrome means organ dysfunction caused by intra-abdominal hypertension. What is intra-abdominal hypertension? Normal intra-abdominal pressure is 5 to 7 mm mercury. If intra-abdominal pressure rises more than 12 mm mercury in adults or more than 10 mm mercury in children, it is considered as intra-abdominal hypertension. A sustained rise in intra-abdominal pressure more than 20 mm mercury in adults or more than 10 mm mercury in children, together with organ dysfunction or organ failure, is known as abdominal compartment syndrome. Intra-abdominal hypertension is graded into 4 types as follows, according to severity. If the pressure is within 12 to 15 mm mercury, it's considered as grade 1. 16 to 20, grade 2, 21 to 25 is grade 3, and more than 25 is considered as grade 4. How do you measure intra-abdominal pressure? It is measured via the urinary catheter, as bladder is inside the abdominal cavity, and bladder pressure directly reflects the intra-abdominal pressure. Rise in intra-abdominal pressure causes the abdominal coverings like skin, muscles, and fascia to stretch. And when they reach a certain limit, they can't stretch anymore. Then increased pressure starts to compress the internal organs, making them to collapse. As pressure rises higher and higher, it not only compresses the internal organs, but also the vessels, leading to ischemia and organ dysfunction. Compression on inferior vena cava leads to reduced venous return to the heart, then reduced cardiac output, blood pressure, and reduced organ perfusions. Due to ischemia, oxygen delivery to the cells is impaired, leading to anaerobic metabolism. The end product of anaerobic metabolism is lactic acid, leading to accumulation of lactate in circulation. Almost any organ can be affected in abdominal compartment syndrome. Reduced blood flow to the brain leads to hypoxic encephalopathy. The patient may present with confusion, convulsions, and coma. Due to liver ischemia, liver is unable to clear toxins. There is decreased lactate clearance by liver and also by kidneys, causing lactic acidosis. Reduced renal blood flow may lead to reduced GFR, causing oliguria, anuria, and renal failure. Adrenal ischemia leads to adrenal insufficiency and inability to produce adrenal hormones like glucocorticoids, mineralocorticoids, and sex hormones. Glucocorticoids and mineralocorticoids insufficiency is dangerous, as it can cause salt and water excretion and potential hypovolemia, which is also known as Addisonian crisis. Reduced blood flow in gastrointestinal vessels lead to mesenteric ischemia. Reduced blood flow in mesenteric vessels causes bowel ischemia, then bowel perforation, and peritonitis, leading to additional fluid accumulation. Prolonged mesenteric ischemia is followed by paralytic ileus, which means a reduction in intestinal motility and delayed passage of GI contents. This favors bacterial proliferation, leading to inflammations of the intestines. These conditions lead to further rise in intra-abdominal pressure. Ischemia of stomach causes reduced gastric peristalsis, the condition also known as gastroparesis. Pressure on aorta causes poor blood supply to the lower limbs. This gives rise to pain and numbness in the feet. Due to pressure on inferior vena cava, venous return from femoral veins to inferior vena cava is markedly reduced. This results in pooling of blood in the lower limbs, which promote formation of peripheral edema and deep vein thrombosis, or DVT. A rise in intra-abdominal pressure causes elevation of diaphragm. This causes narrowing of thoracic cavity, which results in increased intrathoracic pressure as well. Increased intrathoracic pressure causes a direct compression on heart, lungs, and great vessels. Compression on lungs leads to atelectasis or lung collapse, reduced lung volume, respiratory distress, and respiratory failure. Due to compression of aorta, systemic vascular resistance or afterload is increased. As a result, mean arterial pressure remains stable, despite a decrease in venous return and cardiac output. Pulmonary vascular resistance or pulmonary hypertension occurs due to compression of pulmonary vasculature. Pressure on the heart causes a rise in right atrial pressure, which further blocks the venous drainage from SVC into right atrium. This leads to increased central venous pressure or JVP. Due to increased central venous pressure, cerebrospinal fluid cannot drain properly. This may cause the ventricles to swell up, causing hydrocephalus and increased intracranial pressure. Keep in mind that in abdominal compartment syndrome, not only intra-abdominal pressure, but also intrathoracic as well as intracranial pressure are elevated. A rise in intra-abdominal pressure pushes the stomach upwards, causing hiatus hernia and gastroesophageal reflux disease. Increased intra-abdominal pressure also promotes formation of bilateral inguinal hernia. The three cardinal signs of abdominal compartment syndrome are abdominal distension, difficulty in breathing, and reduced urine output. Abdominal compartment syndrome can be divided into three types: primary or acute, secondary, and chronic. If it occurs due to underlying intra-abdominal pathology, it is called primary or acute. Sudden accumulation of any kind of fluid inside peritoneal cavity may contribute to acute abdominal compartment syndrome, most commonly the blood. Any abdominal trauma or injury to the abdominal organs account for hemoperitoneum. Secondary abdominal compartment syndrome occurs in patients who have not experienced any intra-abdominal injury. Collection of any fluid like ascites in acute pancreatitis, leakage of gut contents in perforated peptic ulcer, ruptured aortic aneurysm, ruptured ectopic pregnancy, fluid overload after massive blood transfusion, or aggressive fluid replacement may contribute to secondary abdominal compartment syndrome. Chronic abdominal compartment syndrome occurs due to certain chronic medical conditions with intra-abdominal fluid accumulation, for example, cirrhosis, chronic kidney disease with long-term peritoneal dialysis, Meigs syndrome, or intra-abdominal malignancy. Clinical features like abdominal pain, abdominal distension, dyspnea, and oliguria are less apparent in chronic cases because the abdominal fascia and skin stretch slowly to accommodate with gradual fluid collection. The gold standard for definitive diagnosis is measurement of intra-abdominal pressure by measuring intravesical pressure by using Foley's catheter attached with a manometer. As for imaging studies, abdominal ultrasound and CT may reveal abdominal distension with increased AP to transverse diameter more than 0.8, which is also known as round belly sign. Bowel wall thickening caused by mesenteric ischemia with superimposed bacterial infection caused by stasis, and collapse of IVC. Management of abdominal compartment syndrome depends upon the severity. In mild cases, fluid restriction, Medications such as diuretics and analgesics might help relieve the pain and abdominal distension. In moderate cases, consider interventional therapies like abdominal paracentesis, which is a procedure to remove fluid from peritoneal cavity by puncturing with a needle. Gastric decompression using Rouse tube. Bowel decompression using rectal catheter. Bladder decompression using Foley's catheter. In severe cases, consider the following measures. Stop enteral nutrition to avoid GI overload. Temporary neuromuscular blockade to make paralysis of the abdominal wall muscles. This improves the elasticity of abdominal wall and thereby decreasing the intra-abdominal pressure. If the patient is unresponsive to the treatments, consider decompressive surgery. In decompressive surgery, a midline incision was made, and ascites drainage was performed. A gauze was spread in the abdominal cavity. 2 drainage tubes were inserted. A sterile drape was used to cover the wound. One important complication after decompressive surgery is reperfusion syndrome. This refers to the damage to the tissues and organs after restoration of blood flow after a prolonged ischemic state. After restoration of blood flow, there is production of reactive oxygen-free radicals from the previously ischemic cells, which cause direct toxicity to the tissues. Therefore, reperfusion itself may paradoxically cause further organ damage. This can be prevented by giving fluid replacement immediately after decompression, so that the body is able to eliminate or wash out the excess-free radicals. That's all for now. See you guys in the next video. Study hard and take care.